Hello everyone. In this video, we will discuss unintentional weight loss, how to approach, how to do the investigations, and how to make a proper diagnosis. In our OPD, one of the major complaint that patient says ki there is a weight loss. So whether that weight loss is due to some benign condition or some malignancies, this is very important. So let's discuss the definition of significant unintentional weight loss. It means a weight loss of more than 4.5 kgs or more than 5% of the body weight over a period of 6 to 12 months. Causes. The most common cause of the weight loss, these are gastrointestinal disorders. These include most common non-malignant organic etiologies like peptic ulcer disease, inflammatory diseases, chronic pancreatitis, celiac disease, which leads to malabsorption, or oral problems like dental problems. But the most important is the malignancy. We have to rule out the malignancy. It can be because of GI malignancies, hepatobiliary malignancies, hematological like leukemias or lymphomas, CA lung, breast cancers, ovarian cancers. Important endocrine disorders include diabetes mellitus, hyperthyroidism, and adrenal insufficiency. Infections. Any chronic infection can lead to weight loss due to release of the cytokines like TNF alpha. TNF alpha is a catabolic cytokine. Subacute bacterial endocarditis, HIV infection. Cardiovascular disease include cardiac cachexia, which is seen in chronic heart failure patients, or mesenteric ischemia, in which there is a postprandial pain. So, a patient will decrease oral intake. Neurological illness like stroke, multiple sclerosis, or it can be dementia, pulmonary disorders like COPD or emphysema. Medications which leads to anorexia, which leads to gastritis or vomiting, they lead to weight loss. These include sedatives, antibiotics, NSAIDs, serotonin reuptake inhibitors, metformin, SGLT inhibitor, or GLP agonist. This group of the drug which is used in diabetes leads to weight loss. Levodopa and ACE inhibitors. Now, how to approach a patient if there is an unintentional weight loss? Most important aspect is the history, because on the basis of the history, we decide which investigation we should advise to the patient, because rather than blindly writing all the investigation which is not cost effective, we should be selective according to the patient clinical presentation. Gastrointestinal problems can be dysphagia, which is suggestive of oropharyngeal cancers like difficulty in swallowing. It could be abdominal pain, suggestive of peptic ulcer disease. Right upper quadrant pain and jaundice is suggestive of hepatomas. Postprandial pain is due to mesenteric ischemia or peptic ulcer disease. Heartburn seen in Zollinger-Ellison syndrome. Diarrhea, it is a feature of IBD or celiac disease. Blood in the stool is suggestive of IBD or some malignancies. Black stools due to upper GI bleed, or oily or floating stools suggestive of fat malabsorption seen in any celiac disease, Whipple disease, or tropical screw. Genitourinary include hematuria, suggestive of vasculitis leading to glomerulonephritis. Lower urinary tract symptoms might be suggestive of prostate cancer. Lower urinary tract symptoms like urinary urge or hesitancy, poor stream of urine flow. Lower pelvic pain can be suggestive of ovarian cancer. Neurological disease like Parkinson can present as tremors or rigidity, or there can be dementia. Endocrine disease, fatigue, palpitation, heat intolerance, suggestive of hyperthyroidism. Polyuria, polydipsia seen in diabetes. Fatigue, orthostatic hypotension, or there is a drop in the blood pressure on standing. Weakness is suggestive of adrenal insufficiency. For pulmonary causes, hemoptysis or cough seen in tuberculosis or CLR. Dyspnea and wheeze seen in emphysema and COPD patients. Most important is the medication review, whether patient is taking any particular medications which can lead to low appetite. Psychosocial aspects like if a patient can afford food intake, or there is some social issues or depression elements, or patient is living alone. So those aspects should be very important in a patient, especially elderly patient coming to your OPD. Then clinical examination. Clinical examination, general physical examination like tachycardia will suggest hyperthyroidism. Hypotension can be infection, can be adrenal insufficiency. Hypertension seen in pheochromocytoma. Fever seen in infection or malignancies. Some malignancies can cause fever, especially the blood malignancies. Mental status should be checked, whether patient has some depression or altered mental status seen in hyponatremia or hypercalcemia due to some cancer as a part of paraneoplastic syndromes, or cognitive impairment seen in dementia. Lymphadenopathy should be checked, especially the supraclavicular lymph node, which is suggestive of the GI malignancies. Then in the GIT tract, we should check for hepatomegaly, splenomegaly, or ascites. They might be suggestive of some malignancies. Bruit, suggestive of mesenteric ischemia. Genitourinary, we should check any mass lesion, whether it is a rectal, prostate, or pelvic masses. Cardiovascular system, we should look for a murmur like new regurgitant murmur, suggest infective endocarditis, or heart failure signs like crepitations in the lung, S3 heart sound, or elevated GVP. Pulmonary causes, we should check for the pleural effusion, like there should be a dullness on percussion, suggestive of malignancies. Hyperinflation chest, suggestive of COPD. Crepitations or constipation, chronic lung diseases. So we have to do a thorough systemic examination. Dental examination is equally important. We will look for poor dentition, where that can be the reason for poor oral intake, or it can be a risk factor for infective endocarditis. Now the basic lab test. So instead of writing all the tests, just start with basics. So if on the basis of the clinical history, it is suggestive of some particular system involvement, then go according to that system involvement. But if there is no system involvement, which is obvious on the clinical examination and history, then go for a basic lab test. What are these basic lab tests? These lab tests include a complete blood count to check for the anemia, to check for total leukocyte count, serum electrolytes, especially for sodium and potassium, which can be altered in adrenal insufficiency, or calcium hypercalcemia can be seen in adrenal insufficiency. Serum glucose should be checked to rule out diabetes, because some patients they are not aware of their diabetes status and there is a weight loss. You just check the blood glucose level and it is identified as uncontrolled blood sugar levels. Creatinine and urea for chronic kidney disease, because chronic kidney disease also lead to weight loss because of its catabolic nature. Urine analysis to rule out any glomerulonephritis, to rule out any proteinuria. Liver function test to rule out chronic liver disease, cirrhosis. Thyroid stimulating hormone, very important to rule out hyperthyroidism. And very, very important, stool heme test, that is a stool occult blood. This should be checked, and I practice to advise that there should be 3 samples of stool occult blood, because that can detect some malignancy, GI malignancies. So this is a basic test which should be done in any patient who is coming to you with unintentional weight loss, and system wise there is no obvious cause. While optional tests are HIV if there is high risk factor for HIV, and age and gender appropriate screening can be done for malignancies like pap smear in female, or rectal examination, sigmoidoscopy or colonoscopy for colorectal conditions, like if there is a family history of colonic cancers, or for breast cancer mammography. Now, indicators of likely malignancy. So these are the indicators, like if the patient has weight loss with age of more than 80 years, WBC count are high, ALP is high, and LDH is high, LDH more than 500. So if these are present, then the likely chances of the malignancy will be there. And these are the references. Now, case-wise approach. So this is very important. Like case-wise, you should approach so that unnecessary investigation should be avoided, and you should not miss any important cause of the weight loss. So if a patient comes to you, these are the 4 aspects. proper history, detailed physical examination, suspected diagnosis, and the first line test for that particular condition you should prescribe. So, if a patient comes with a history of H. pylori infection in the past, peptic ulcer disease, or there is epigastric pain, nausea, hematemesis is there, black color stools are there. So these are suggestive of some sort of malignancy, upper GI malignancy. So stomach cancer will be a likely possibility. So what is the first line test? First line test will be endoscopy with biopsy. Now, the next case, rectal bleeding is there, fresh stool blood is there, abdominal pain and change in the stool caliber is present. Abdominal distension is there, rectal mass is present. So most likely it is some sort of a colorectal cancer. Appropriate test, colonoscopy with biopsy. History of smoking, alcohol use, progressive dysphagia, painful swelling. So that means that some esophageal condition is there which is progressive in nature causing the weight loss. So always rule out esophageal cancer. Upper GI endoscopy is the appropriate test. Unintentional weight loss is very, very common. Indeed, patient present with unintentional weight loss, anorexia, nausea is present. There can be abdominal mass, but most important is icterus. Check for the icterus always, because this is one of the cancer with a poor prognosis, because most of the patient are diagnosed in late stages of this cancer. This is pancreatic cancer. Test ultrasound followed by CT abdomen. Patient has history of cirrhosis, hepatitis B or C infection in the past. Patient has right upper quadrant mass, abdominal tenderness, ascites is present. Always suspect hepatocellular cancer. So liver function test should be advised, alpha fetoprotein and ultrasound abdomen. The basic test, the first line test should be done. Followed by, if it is suspected, then we have to go for a tissue biopsy. History of cough, hemoptysis, chest pain, altered mental status due to hyponatremia, SIADH. These are suggestive of paraneoplastic syndromes. And lung examination is positive. So suspected CA lung. So what should we do? Chest X-ray followed by CT scan. Night sweats, fatigue, malaise, enlarged lymph nodes, and fever, lymphadenopathy, hepatosplenomegaly is positive. So this has got a huge differential diagnosis. Like these symptoms can be present in tuberculosis, these symptoms can be present in malignancies also, lymphomas also. So should suspect these conditions. So the obvious test will be a CBC test, chest X-ray for enlarged lymphadenopathy. LDH will be high, especially in lymphomas, and followed by CT chest and abdomen. Patient has bone pain, infections are there, pallor and pathological fractures, especially in elderly age group. Suspect multiple myeloma, and the test will be urine or serum electrophoresis. History of pelvic pain or abdominal bloating is there, increased abdominal girth is present, adnexal masses are there. So ascites is present. This in female, it is suggestive of ovarian cancer. Go for CA 125 levels and ultrasound pelvis. Breast lump, bone pain. So obvious, always rule out malignancy, CA breast malignancy. So we will go for a mammograph or ultrasound of the breast. Patient has diarrhea, bloating, abdominal pain. There is pallor is present as well as dermatitis herpetiformis. So this is highly suggestive of celiac flu. Go for a anti-TTG test to rule out celiac disease. Now, history of depressed mood, the functional impairment, low energy levels, low libido, poor concentration. So psychomotor slowing is present. Suspect patient is having depression. Go for a DSM. Fear of gaining weight, food restrictions, amenorrhea is there, young female, low BMI, bradycardia, suggestive of anorexia nervosa. So this is a clinical diagnosis. Test will show low counts, hemoglobin, TLC, or low platelets. Bradykinesia, cognitive impairment and dementia. This is highly suggestive of Parkinson disease, and Parkinson disease is a clinical diagnosis. Cognitive dysfunctions, memory loss, taste changes there, cognitive impairment. So highly suggestive of dementia. Cognitive impairment screening test will be done. History of palpitations, tremor, fatigue, heat intolerance. So it is obvious weight loss is present. Patient has tachycardia, fine tremor, hyperreflexia, highly suggestive of hyperthyroidism. Thyroid function test should be done. Cough, night sweats, hemoptysis, dyspnea. Weight loss is more common with reactivation of this infection. So now you have diagnosed it to be a case of tuberculosis. Chest X-ray and sputum AFB test are the first line test. Systemic sclerosis history, diarrhea history, pain and bloating. Examination is totally normal. Bacterial overgrowth should be suspected, and hydrogen breath test is the first line test. Progressive limb weakness, and on the examination we get both the lower motor neuron signs like weakness and muscle atrophy, as well as upper motor neuron involvement like hyperreflexia. So this is highly suggestive of amyotrophic lateral sclerosis, motor neuron disease. It is diagnosed on electromyography. Dyspnea on exertion, fatigue, orthopnea, PND. So these are the classical symptoms of heart failure. S3 will be present, crepitations in the lung will be present, elevated GVP will be there. So cardiac cachexia syndrome. First line test is echocardiogram. Polyuria, polydipsia, dehydration. So obviously this is diabetes. Go for HbA1c test and sugar test. Fatigue, decreased appetite, diarrhea can be there, and most important, hypotension, orthostatic hypotension, hyperpigmentation. So this is a case of adrenal insufficiency. Morning serum cortisol will be low. History of cough, dyspnea, fatigue, arthralgia, photophobia due to uveitis, lymphadenopathy can be there, and this is sarcoidosis. So go for a chest X-ray and ACE levels. IV drug abuse, unprotected sex or needle stick injury is there, fever, skin rash, muscle wasting is present, suspect HIV infection, especially in a high risk group. HIV test will be advised. Now come to the management. So the most important is a proper clinical history and examination. Based on the appropriate test, we diagnose a cause of the weight loss and we should treat that cause. The management of the weight loss is treat the cause. While if there is no cause identifiable, in 1/3 of the patients, no cause is identifiable. So what should we do? Lifestyle modifications. So first is calorie intake. So a proper dietitian consultation should be taken. 35 to 40 kilocalories should be taken with more than 20% of protein content. Now, how the food should be taken? There should be high energy supplements in between the meals, not with the meals, but in between the meals. High energy supplement will be there, means ki energy dense drinks will be given to the patient. Small frequent meals should be given, because if a heavy meal is taken, abdominal gastric distension will occur and that will suppress the appetite. Eating favorite food so that patient will have urge to take the food. Avoid gas producing foods like carbonated drinks should not be given, or high proteins which causes gas or bloating should be avoided. Patient to patient it will vary. Adequate oral health should be advised, like proper dental hygiene should be there. Eat in the company, means it should be with the friends or the relatives. When we eat with the friends or the relatives, the intake is more. Regular exercise should be advised. Now the drugs. So we give the drugs which increases the appetite. So serotonin antagonist popularly which is given is cyproheptadine. It is available in the form of tablets or in the form of syrup also. So the dose is 12 to 16 milligram per day in divided doses. Anabolic agents, these are experimental agents not approved till now, like growth hormones or androgen therapy. Anti-catabolic agents can be given like dietary and anti-cytokines like omega-3 fatty acids, or it can be pentoxifylline, but still in the experimental stages, or anti-cytokine activity of melatonin. It can be given in 3 milligrams or 5 milligram of strength. While in selected patients, especially who are having depression, so antidepressant agent, mirtazapine can be given 15 to 30 milligrams per day at bedtime can be given. So these are some of the agents which should be used when there is idiopathic weight loss. So this is all about the how to approach a case of unintentional weight loss. So if you have your own experiences or you want to give some recommendation or have any questions, you can put in the comment section. Thank you.